start with the pain. That's usually how the story begins in the emergency room, isn't it? It's not about the anatomy textbook sitting on a shelf. It's about the person walking through the door.
It is. And in the case of the thorax, the chest, the pain is rarely subtle. It's loud, and it demands your attention immediately.
We're looking at a case today, drawn directly from the opening of our source material, that honestly, it terrified me a little. It really sets the stakes perfectly. Imagine a 54-year-old woman. She comes in, or maybe she's rushed in on a gurney, and she is just gripping her chest. She doesn't just say it hurts. She describes the sensation as knife-like.
Tearing is the other word you'll often hear in this specific scenario. Tearing, ripping, shearing. It's a very visceral, violent kind of description.
Right. And she locates it right in the center of the chest, anteriorly. But, and here is the detail that really matters, the clue that should make your ears perk up. She feels it radiating straight through to her back, right between the shoulder blades.
That specific radiation pattern that is a massive red flag. It's almost a signature for what's happening.
But the clinicians are, initially puzzled. They go through the standard workup. They take her blood pressure. In her right arm, it is sky high. We're talking 200 over 110, a hypertensive crisis. But then, just for thoroughness, they check the left arm, and it's normal, maybe even a bit low, 120 over 80.
And that asymmetry, the huge difference between the left and right, that is the smoking gun. You're looking at a classic presentation of an aortic dissection. The inner lining of the body's main pipeline, the aorta, has literally torn.
It's a physiological catastrophe, but what I want to understand, what we're really diving into today, is the architecture behind that catastrophe. I mean, why did her left arm pressure just plummet? Why did she feel chest pain in her back?
Well, it all comes down to the wiring and the plumbing. The dissection flap, that loose piece of the intervessel wall that tore off it, likely folded over like a trapdoor and physically blocked the opening to the left subclavian artery.
The pipe feeding the left arm.
Exactly. If you block the pipe, the pressure downstream just drops. It's simple hydraulics, really.
Okay, so that explains the pressure difference. But the back pain, why is she feeling a heart problem between her shoulder blades?
That's a wiring issue. The heart and the great vessels, specifically the thoracic aorta, they don't have touch sensors like your skin does. They use the autonomic nervous system to scream for help. And those pain signals, they travel back to the spinal cord, entering at the same level, specifically segments T1 to T4, as the somatic nerves coming from your upper chest and your back.
So the signals just get mixed up in the switchboard.
Exactly. Your brain gets this high-intensity signal shouting, "Trouble at T1, T4." And the brain, based on a lifetime of experience, assumes the pain is coming from the skin supplied by T1, T4, because that's where you usually get signals from. It projects the pain to the chest wall and the space between the shoulder blades. It's a classic case of crossed wires.
That concept of crossed wires and hidden plumbing is exactly where we're going today. We're doing a deep dive into the thoracic cavity. Our guide for this is Snell's Clinical Anatomy, specifically the chapter titled The Thorax, Part 2, Thoracic Cavity.
And I think it's important to make a quick disclaimer before we metaphorically crack the chest open. This is our interpretation. It's a conceptual framework. We are not replacing the text. Think of this as a ready reckoner, a way to organize your mind so that all those details actually stick.
We really want to urge you, the learner, that reading is, well, it's becoming a bit of a lost art. We're hopeful that listening to this deep dive will make you curious enough to actually go back and read the chapter. We're giving you the tour, but you really need to study the map yourself.
Absolutely. The goal here is to turn the thorax from a static list of Latin names into a dynamic, moving system. We want you to see it as the engine room of the body.
So let's enter the room. We're going to break this down into 4 sections: the geography, the airbags, the engine, and finally, some clinical integration. Section 1, the geography of the chest, or as the anatomists call it, the mediastinum.
The very first thing to realize about the geography is that your eyes deceive you. I mean, if you look at a skeleton hanging in a classroom, the rib cage looks massive. You assume the thoracic cavity, the space inside, is this huge cavernous hall.
But it's an optical illusion.
Completely. The actual cavity is much, much smaller than the external cage suggests.
Why is that? What's taking up the space?
It's the floor, the diaphragm. We tend to think of the diaphragm as like a flat floor at the bottom of the ribs, like the bottom of a box. It's not. It's a dome, a very aggressive, high-rising dome that pushes way up into the chest cavity. Snell uses the term invaginates. It rises like a piston after it fires.
How high are we talking? Give us a landmark.
Well, on the right side, because you've got the liver sitting right underneath it and pushing up, the diaphragm can reach as high as the 5th rib.
5th rib. That's nipple level.
Yeah, it's nipple level.
Wow, that is incredibly high. That radically changes how I think about trauma. If someone gets stabbed in the chest at the level of the nipple,
You have to assume the knife went through the pleura, through the diaphragm, and into the liver. It's a thoraco-abdominal injury until you can prove otherwise. The chest on the outside is covering the abdomen on the inside. You just cannot trust the surface to tell you what lies beneath.
okay, so the floor is much higher than we think. Now let's talk about the walls. The chest isn't just one big open room, is it?
No, it's more like a duplex. You've got a lung on the right and a lung on the left. And separating them is this thick central partition called the mediastinum.
Mediastinum, it literally means middle septum. I always visualize this as a solid wall, like drywall, rigid.
And that is the mistake most students make. And it's usually because they learn their anatomy on cadavers.
Yeah.
In a chemically preserved body, the mediastinum is stiff. It's hard. But in you and me, in a living, breathing human, it is highly mobile. It's soft. It pulses with every single heartbeat. It shifts with every breath.
So why does that mobility matter clinically? I mean, why should a listener care if it's soft or hard?
Because that mobility makes it incredibly susceptible to pressure. Imagine the chest as two pressurized balloons, the lungs, with a soft, heavy curtain hanging between them. Now, if you puncture one of those balloons, let's say you get a pneumothorax on the left side where air rushes into the chest cavity, the whole pressure balance is destroyed.
So air just builds up on that injured side.
Right. And because that central curtain, the mediastinum, is mobile, that high pressure starts to push the entire wall toward the healthy side.
It shifts over the whole thing.
The whole thing. It's called a mediastinal shift. And this is incredibly dangerous for two reasons. One, it starts to compress the good lung, so now you can't breathe properly on either side. But two, and this is the killer, it kinks the great vessels. The superior and inferior vena cavae are like soft garden hoses bringing blood back to the heart. If you shove the mediastinum over, you kink those hoses shut.
So a hole in the lung can actually stop the heart just by cutting off its blood supply.
Exactly. That is a tension pneumothorax. If the mediastinum were a rigid wall, like in a cadaver, the other side would be safe. But because it's mobile, a simple puncture becomes a life-threatening emergency in minutes.
That is a powerful image. The central wall is dynamic. Now, inside this wall, this mediastinum, Snell talks about a magic plane.
Ah, yes. The sternal angle to T4. If you learn only one landmark in the chest, this is it. This is the Rosetta Stone of thoracic anatomy.
Okay, let's help the listener find it on themselves right now. If you're listening, just take your finger and run it down your throat until you hit that little notch at the top of your breastbone.
That's the suprasternal notch.
Now go down another inch or two. You'll feel a horizontal bony ridge. It feels like a little speed bump on your sternum.
That is the sternal angle. It's where the manubrium, the handle of the sternum, joins the body. Now, I want you to visualize a laser beam shooting straight back from that ridge horizontally right through your chest. It's going to hit your spine at the fourth thoracic vertebra, or T4.
And this is the magic plane. Why is this one imaginary line so important?
Because it is the architectural anchor for the entire thorax. It is, without a doubt, the busiest intersection in the entire body.
Okay, run us through the checklist. What happens at the T4 plane?
Honestly, what doesn't happen there? The aortic arch begins and ends at this level. The trachea, your windpipe, it comes down the neck, but it stops and splits into the two bronchi exactly at this level.
So the airway divides right there at T4.
Correct. The azygos vein, which is the main drainage pipe for the chest wall, it arches over the root of the lung to dump into the superior vena cava right at this level. It's like all the major engineers met up and decided, okay, let's just put all the important junctions right here.
It effectively slices the mediastinum in half too, doesn't it?
It's the great boundary line. Snell uses this plane to categorize the space. Everything above that T4 plane is the superior mediastinum, and that contains all the big pipes, the trachea, the esophagus, the great vessels coming off the heart.
And everything below it.
That's the inferior mediastinum. And that area below the plane gets subdivided again, but this time vertically. Think of it as front, middle, and back.
Okay, let's break those down.
The anterior mediastinum is a tiny little space right behind the sternum, but in front of the heart. In kids, it contains the thymus gland. In adults, it's mostly just some vestigial fat. The middle mediastinum is the main event that contains the heart and its protective sac, the pericardium. And the posterior mediastinum is sort of the alleyway behind the heart, containing the esophagus on its way down and the descending aorta running along the spine.
So it's a grid system. T4 cuts it horizontally, and the heart cuts the lower part vertically.
Precisely. It turns what looks like a jumble of tubes into a completely navigable map.
Before we move on, I want to do a quick check-in. Listener, can you visualize that T4 plane? Can you feel that ridge on your chest? If not, maybe just pause, find it, and imagine that cross-section. It's absolutely crucial for everything else we're about to discuss.
It really is. It's the reference point for radiologists, for surgeons, for everyone.
All right, let's step out of the central partition and look at the residents of the duplex. The lungs, or as I'm calling them in this deep dive, the airbags.
Airbags works well. But to understand how they inflate, you first have to understand the wrapper they come in, the pleura.
Snell uses a really helpful analogy here, the fist in the balloon.
It's a classic for a reason. Imagine a slightly underinflated balloon. Now, take your fist and push it into the side of the balloon. Your fist represents the developing lung. The rubber of the balloon that is now stretched tightly over your knuckles. That is the visceral pleura.
Visceral means organ, so it's stuck to the organ.
Yes. It is physically attached to the lung tissue itself. You can't peel it off without damaging the lung.
And the rest of the balloon, the outer layer that isn't touching your fist.
That is the parietal pleura. That's the layer that lines the inside of the rib cage and the top of the diaphragm. And here's the concept that, trips people up. The space between the two layers, where the air inside a balloon used to be, that is the pleural cavity.
But in a healthy person, there's no air in there, right?
Zero. None. It's a potential space. The two layers, visceral and parietal, are pressed right up against each other. There's just a microscopic film of lubricating fluid between them.
What's the function of that fluid then?
Two things: lubrication and surface tension. Think of two wet glass slides stuck together. You can slide them back and forth very easily. That's lubrication, allowing the lung to move smoothly as you breathe. But try to pull them straight apart. You can't. That's surface tension.
And that tension is the magic. When the ribs expand, they pull the outer layer, the parietal pleura. The outer layer then drags the inner layer along with it because of that tension, and the lung itself inflates.
Exactly. But this beautiful setup has a vulnerability. If that potential space starts to fill with something else, blood, pus, fluid, it becomes a real space. This is a pleural effusion.
Snell notes that it takes about 300 milliliters of fluid before it's even visible on a standard X-ray.
Right. And if fluid takes up that space, the lung can't expand. It's physics again. Two things can't occupy the same space at the same time. The fluid creates positive pressure and effectively crushes the lung.
There's a fascinating detail about pain here that I found really surprising. I mean, I could have a tumor growing deep inside my lung and feel absolutely nothing.
It is scary, but it's true. The visceral pleura, the layer on the lung itself, has no pain receptors. It's supplied by the autonomic nervous system.
Yeah.
It's blind to pain. You can cut it, burn it, a tumor can invade it. You'd feel nothing.
But the outer layer.
The parietal pleura is a completely different story. It's supplied by the somatic nerves, the intercostal nerves, and the phrenic nerve. It is exquisitely sensitive to pain. So if you have pneumonia, for example, you typically won't feel any sharp pain until the inflammation reaches the surface of the lung and starts rubbing against that outer wall.
That's pleurisy.
That's pleurisy. That sharp, stabbing pain you feel with every single breath. It's the parietal pleura screaming for help. And it's a localized, precise pain, totally unlike the vague referred pain of the heart we talked about earlier.
Let's look at the plumbing leading into these bags. The trachea. We know it splits at the magic plane, T4. But it doesn't split evenly, does it?
No, not at all. And this leads us to what I call the inhaled peanut rule.
I remember this from med school stories. If a kid swallows a marble or a peanut, where does it end up?
It goes right down the pipe. And by right, I mean the right main bronchus.
Why the right side, specifically?
It's just geometry. The right main bronchus is wider, it's shorter, and it's much more vertical than the left one. It's almost a straight shot down from the windpipe.
And the left one?
The left main bronchus has to make a much sharper angle to get around the heart, which is pushing in from that side. So purely due to gravity and the path of least resistance, foreign objects almost always fall into the right lung.
So if you're X-raying a choking child, check the right side first. Speaking of the lungs themselves, they aren't identical twins either.
No, more like cousins, maybe. The right lung is the big brother. It's heavier, it's a bit larger, and it has 3 lobes, upper, middle, and lower. The left lung is smaller because it has to share its apartment with the heart. The heart pushes into the left chest, creating this big indentation called the cardiac notch.
So the left lung only has 2 lobes.
Upper and lower. But it has this cool little feature called the lingula. It's a little tongue-like projection on the bottom of the upper lobe. Lingula literally means little tongue. It sort of wraps around the apex of the heart. Anatomically, it's what corresponds to the middle lobe of the right side.
Let's talk mechanics. How do we actually get air into these things? Snell breaks down the mechanics of respiration into 3 dimensions. I love the metaphors here.
It's just simple engineering, really. To get air in, you have to increase the volume of the chest box. And you can expand that box in 3 directions: vertical, transverse, and anteroposterior.
Let's take vertical first.
That's the diaphragm. When it contracts, it flattens out. It moves down like a piston in a cylinder. This makes the box taller from top to bottom. This is the main driver of quiet breathing.
Okay. Transverse, making the chest wider from side to side.
For that, think of a bucket handle. When the handle is resting against the side of the bucket, it's low. When you lift the handle, it swings out and away from the bucket. The ribs are the handles. As the intercostal muscles lift them, they swing laterally, widening the chest.
And finally, anteroposterior, front to back depth.
That's the pump handle motion. Imagine an old-fashioned water pump. The sternum is the handle. As the upper ribs lift, they thrust the sternum forward and up. This deepens the chest from front to back.
So every single breath is a 3D expansion. Piston down, bucket handles out, pump handle forward.
It's a symphony of movement. And when that movement stops, or if it's blocked by fluid or air, the entire engine starts to fail.
Which brings us perfectly to the engine itself. Section 3, the heart.
We've mapped the room, we've checked the airbags, now we look at the pump. But again, just like with the lungs, we have to start with the wrapper, the pericardium.
Why does the body wrap everything in these double layers?
It's all about friction control. The heart beats roughly 100,000 times a day. If you just rub directly against the sternum or the lungs, it would blister and get inflamed. So it sits inside the serous pericardium, which is another one of these double-layered, lubricated sacs.
But there's an outer layer too, right? The fibrous pericardium.
That's the tough, leathery bag on the very outside. It does 2 things. It anchors the heart in place so it doesn't flop around when you jump, and importantly, it prevents the heart from overstretching. But that toughness is a real double-edged sword.
How so?
Because it doesn't stretch
Yeah.
at all. So if you get a stab wound to the heart or a vessel ruptures inside that sac, the blood starts to fill the space. This condition is called cardiac tamponade. And since the leather bag won't expand, the pressure turns inward.
It crushes the heart.
Effectively, yes. It prevents the heart from relaxing and opening up during diastole. And if the heart can't relax, it can't fill with blood. If it can't fill, it can't pump anything out. The engine runs dry even though the body is full of blood.
So that's a mechanical arrest. It's not an electrical problem, it's a plumbing and space problem.
Exactly. You have to physically puncture the bag and drain the fluid to save the person's life. The heart muscle itself is usually fine. It just needs room to move.
Inside the pericardium, Snell mentions these hidden tunnels, the transverse and oblique sinuses. These sound like obscure trivia. Do they really matter to a listener?
To a cardiac surgeon, they matter immensely. Let's just focus on the transverse sinus. It's a natural tunnel that runs behind the 2 great outflow tracts, the aorta and the pulmonary trunk, but in front of the atria.
A tunnel behind the main pipes.
Yes. A surgeon can literally slide their finger right through that tunnel. And this allows them to pass a clamp or a ligature around the aorta and pulmonary artery. This gives them total control. They can stop blood flow during open heart surgery. It's like the anatomy provided a built-in handle for the surgeon to grab onto.
That's incredible. It's a feature, not a bug. Now let's orient the heart itself. Snell says it is a pyramid that has fallen over.
This is hard to visualize, so let's slow down here. We tend to think of the heart as standing straight up, like the heart symbol on a Valentine's card. It doesn't. It's tipped over on its side, pointing left.
Okay, explain that.
The base of the heart is actually the posterior surface. It's formed mostly by the left atrium, and it sits right up against the spine, just separated by the esophagus.
So the base is at the back.
Correct.
Yeah.
And the apex, the pointy bit, points down, forward, and to the left. That's formed entirely by the left ventricle. That's the part that taps against your chest wall in the 5th intercostal space. That's your heartbeat.
So it's lying down. Base at the back, apex at the front left. That's a much better mental image.
It is. Once you get that, the blood flow makes more sense.
Let's look at the fuel lines for this engine, the coronary arteries. These are so crucial.
Probably the most medically significant arteries in the entire body. They come off the aorta right at the very start, emerging from the aortic sinuses. They get the very first sip of fresh oxygenated blood leaving the heart.
And we have a right and a left.
The right coronary artery, RCA, loops around the right side of the heart. Crucially, in most people, it supplies the SA node and the AV node, the electrical command centers of the heart, the pacemaker and the junction box.
So if I have a blockage in my right coronary artery, what's likely to happen?
You often get electrical failure, arrhythmias, heart blocks, bradycardia, which is a very slow heart rate. The pump muscle might be okay, but the spark plug is dead.
And the left.
The left coronary artery, LCA, is the heavy lifter. It's short and splits almost immediately. One branch, the anterior interventricular artery, which clinicians always call the LAD, for left anterior descending, runs straight down the front of the heart between the ventricles.
I've heard the LAD called the widowmaker.
It is a grim nickname, but it's anatomically accurate. The LAD supplies the bulk of the muscle of the left ventricle. And remember, the left ventricle is the main pump for the entire body. It has the thickest walls, it does the most work. If you block the LAD, you knock out the main engine. That's a massive and often fatal heart attack.
So, broadly speaking, a right coronary blockage equals electrical issues. A left blockage equals pump failure.
That's a very good heuristic, a great rule of thumb for any learner to remember.
Okay, we've covered a lot of ground. Geography, airbags, engine. I want to move to our last section, clinical integration. I want to test our listeners and myself, really, with a scenario based on what we've discussed.
Let's do it.
Okay. Imagine you're a medical student on your first rotation. You're looking at a chest x-ray. It's a standard PA view. You see a massive white shadow taking up the entire left side of the chest, a complete whiteout.
Okay, so we can't see any of the lung fields on the left. It's completely opaque.
Exactly. Now, you look at the trachea, that dark air column in the neck, and you notice it is pushed way over to the right side, the opposite side. The attending doctor turns to you and asks, is this a collapsed lung? Or is the chest full of fluid?
This is the push versus pull test. It's the ultimate check of your understanding of thoracic pressure dynamics.
Walk us through it. How do you know the answer?
Okay, just think about volume. If the lung had collapsed, what we call atelectasis, it would lose volume. It shrinks, right? That creates a vacuum or negative pressure on that side. So the mediastinum and the trachea would be pulled toward the white shadow.
So trachea pulled toward the problem equals collapse.
Right. But in your scenario, the trachea is pushed away to the right. That means something is taking up space on the left. It's adding volume. That tells you it's a massive pleural effusion. So fluid, or maybe a huge tumor. It is physically shoving the mediastinum away from it.
That is such a simple, clean rule. Push implies a space-occupying thing like fluid or a mass. Pull implies a loss of volume, like a collapse.
And it saves lives in the ER, because the treatments for those two things are completely different.
Just quickly, you mentioned standard PA view. Snell makes a point about PA versus AP x-rays. What does a non-radiologist really need to know about that?
It's all about magnification. A PA view means post-row anterior. The X-ray beam shoots from your back to your front with your chest pressed against the film. This puts the heart, which is in the front of the chest, close to the film. So you get a true, actual size shadow.
An AP.
Anteroposterior. The beam comes from the front. This is usually done with a portable X-ray for a sick patient who's lying in bed and can't stand up. The film is behind their back. Now, because the heart is far away from the film, its shadow spreads out.
Like a shadow puppet.
Exactly like a shadow puppet. The further your hand is from the wall, the bigger and fuzzier the shadow gets. On an AP film, the heart looks artificially huge.
So the takeaway is, don't diagnose an enlarged heart, cardiomegaly, on a bedside portable X-ray. You might just be seeing the shadow puppet effect.
Correct. Always check the label. Is it PA or AP? It changes everything.
I want to loop back to where we started. The woman with the tearing pain, we explained the why of her symptoms using anatomy.
The referred pain.
Can we just crystallize that visceral versus somatic concept one last time? It feels like the key to understanding all chest pain.
Absolutely. Somatic pain comes from the body wall, your skin, your muscles, the parietal pleura. The wiring is precise. It's high fidelity. If you prick your finger, you know exactly where it is.
It's pinpoint accuracy.
Visceral pain comes from the organs. The wiring is diffuse. It's low fidelity. The organs don't really have a GPS.
So the heart screams pain, and that signal just hits the spinal cord at the T1, T4 level.
And the brain looks at that signal and says, well, hang on, T1, T4 usually means the inner arm and the upper back. Must be that.
It's a best guess based on past experience.
It is. Yeah. And that best guess is why understanding the wiring diagram, the anatomy, is the only way to solve the clinical puzzle.
We've reached the end of our shift in the engine room. Looking back at this entire chapter from Snell, what is the one big concept you really want the listener to walk away with?
For me, it's the realization that the anatomy is a history book. Snell mentions the embryology of the heart, how it starts as a simple tube and then it folds over and over on itself because it grows too fast for the space it's in.
The fold.
That folding process creates the sinuses we talked about. It creates the strange orientation of the great vessels. The complex machine we see in an adult is just the frozen history of that folding process. If you can understand how it grew, the weird adult anatomy suddenly makes perfect sense.
Frozen history. I love that.
And the other big takeaway is just movement. The thorax is not static. It's a rhythmic, pressurized machine. Pressures, chloral pressure, pericardial pressure, they dictate function.
We've given you the audio tour. We've pointed out the big landmarks, but you really need to see the map for yourself.
Yes. This deep dive is just the spark. Go to Snell's Clinical Anatomy, find the chapter on the thoracic cavity, look at the cross-sections of the mediastinum, trace the aorta, visualize that T4 plane.
Reading anatomy is an active process. Don't just stare at the pictures. Build the model in your head. Use your own body as a reference point.
Once you do that, I promise you will never see a chest x-ray the same way again.
Thanks for diving deep with us.
Stay curious.